Today we will talk about salivary gland disorders. Now, this lecture will be two parts. We'll talk today about the first part and then we'll talk about the second part later on. So, first we'll talk about the anatomy, how to diagnose the lithiasis, mucoceles, infections, neoplasms, and then the references. Now, the anatomy of salivary glands, we have major salivary glands and minor salivary glands. Major salivary glands include parotid, submandibular, and sublingual glands in pairs. So we have 6 in total. Now, we have the serous and the mucus types and the mixed types. Usually we have 1 liter to 1.5 liters of saliva per day. We have saliva that comes during meals and saliva that is unstimulated. Without any stimulation, the body secretes saliva. Now, in the stimulated part, we have the submandibular gland in the unstimulated, the submandibular gland secretes about 70% and it's mixed between serous and mucus. The parotid about 25%, which is serous. The sublingual about 3 to 4% with the minor salivary glands, about mucus secretions. In the stimulated, the parotid and the submandibular start to become equal, the parotid becoming more, about 55 to 60% the parotid secretions. Now, this is the parotid gland. The facial nerve separates it into superficial and deep lobe. We have the submandibular gland and we have the innervation. Now, all the glands are innervated by the facial nerve. The facial nerve supplies it secretomotor secretions for both the parotid and the submandibular and the sublingual. Now, the lingual nerve and branch, which is called the chorda tympani, they help in the taste and the touch and the pain for the tongue. Now, first, history will give us a very good indication about the swelling. Now, most of the time, if there's an infection or a stone, there will be pain, redness, swelling during meals. Once the food goes away, everything goes back to normal. So history is very important. Now, plain film radiographs can be helpful because they will assist the salivary gland disease in about 80% of stones to 85% appear radiopaque. Mandibular occlusal film is usually preferred. For the submandibular, this is a mandibular film, an occlusal film, showing a stone in the submandibular gland. Now, if this stone is anterior to a line between the 6 to the 6, we would go for, seems like the 5 is missing, so let's say if the 5 is present, we will go for intraoral excision, so just remove this stone intraorally. If it's beyond the 6 to the 6, we will go with extraoral removal. We can have the parotid gland stones appearing on panoramic x-rays and also submandibular stones appearing on panoramic x-rays, sometimes on lateral radiograph, lateral cephalometric. So plain film radiographs can give us an indication if there's a stone, about 80 to 85% of them. Now, cyalography, it's a very gold standard in diagnostic salivary gland radiology, or the cyalogram. Now, it's indicated as an aid for the detection of radiopaque and radiolucent stones. About 15 to 20% of the stones are radiolucent, as well as mucus plugs. Now, the mucus plugs, the cyalograph can be diagnostic or therapeutic. If it's a mucus plug with the cyalogram, the mucus plugs can go away, can be removed. It can be diagnostic to show stones. So it also gives us an assessment for the destruction of the duct parenchyma. About 0.5 to 1 milliliter of contrast material, and it contains a lot of iodine. Now it can be water soluble or oil based. Now 25 to 40% of iodine. Water soluble media is morely preferred because it can be excreted easily by drainage, more easily injected, easier to inject and to pass towards the duct onto the gland easily, more rapid transfusion, and more miscible the salivary secretion, very similar to them. Lithiasis is the disease of multiple stone formations or stone in the gland, causing symptoms. Can be obstruction, reduced salivary flow rate, dehydration, medication like patients who are DN, accumulation of the calcium in the glands, change in the salivary pH with oropharyngeal sepsis, impaired crystalloid solubility. Now, the submandibular gland has 85% of the cases. Most stones appear in the submandibular gland. Why is that? First, because it has the highest calcium concentration. Second, because it has a tortuous path. So it has like a lot of turns in the duct itself. So the calcium can be precipitated on the walls much easier. So because of the high calcium, the high pH, and the tortuous path, the parotid about 10%, the sublingual gland about 5%. Now, radio-opaque stones, 80% of the submandibular gland stones are radio-opaque. 40% of the subparotid gland are radio-opaque. 20% of the sublingual glands are radio-opaque. So, for example, about the 10%, we have about 4% radio-opaque in the parotid. So, the classic signs and symptoms: pain and swelling, diminished salivary flow, lymphadenopathy, mainly on meal times. Treatment: usually we will apply pressure to push the stone and to push any accumulated saliva inside. We prescribe salivary stimulants sometimes. Sometimes, if it's not treatable, we go for excision of the gland if it's large. So here, for example, the swelling, and here's the stone. This can be pushed out of the duct orifice and everything's going to go back to being fine. Now, in children, about 3% of the cases. Males and left sides are more commonly affected. The same idea. Now, if the stone is anterior to a line between the 6 to the 6, we go for intraoral excision. If not, we go for extraoral excision of the gland. Now, mucocele, it's a pseudocyst, not a true epithelial lining. It's usually due to trauma, lip biting, accumulation of the secretions inside of the gland or in the path of the duct. In the lower lip and the buccal mucosa. Now, usually there will be elevated, thin, stretch overlying mucosa with vesicle filled with a clear or blue-gray mucus. Now, there are a lot of talk about it between the mucoses and the ranula. As for the mucoceles, usually they say it's between a mucus juxtaposition cyst and a mucus retention cyst. It's in between these two. It has both factors being present. Now, for the mucoceles, usually we prefer to go for excision with the minor salivary gland, but the highest recurrence rate, 15 to 30%, because another trauma to an adjacent gland has been present. For the ranula, it's the most common lesion of the sublingual gland. Now, it can result from mucus retention or due to inflammation or trauma causing extravasation from the ductal disruption. A simple ranula is confined to the area of the sublingual gland superior to the mylohyoid muscle. If it goes below the mylohyoid muscle, it would be a plunging ranula, and this is very risky. It's closer to the neck. It can cause shortness of breath. Now, the differential diagnosis of floor of the mouth swelling usually includes ranula, lymphoepithelial cysts, epidermoid or dermoid cysts, and tumors. And the management usually for them is to remove the ranula with the sublingual gland. Some studies have talking about marsupialization, but it does not eradicate it completely. There's a recurrence rate that comes back later on. Now, as for the infections, it can be acute or chronic. Now, usually it's an obstructive disease, an ascending infection due to dryness of the oral cavity. Ascending infection, bacteria from the oral cavity goes out through the duct and into the gland, causing the infection. Usually there will be pain, swelling, redness when the saliva is coming to come out, with pus coming out of the ductal orifice. Now, some cases are bilateral, some cases are unilateral. It has a slight male predilection. Usually, mixed bacterial flora is responsible, with the most common organism being present is Staph aureus. Now, how to manage such a patient? First, increase fluid intake. If it's the first time, we can go for just increasing the fluid with an oral antibiotic and watchful waiting for the patient. If not, it's a multiple times, we need to go for admission for the patient, IV fluids and IV antibiotics specific against Staph aureus, cephalosporins or oroxacillin or dicloxacillin, and if it's multiple visits, usually we go for culture and sensitivity for the patient. Now, viral infections or viral periodontitis, it's usually epidemic in kids, the mumps, for winter and spring seasons. Now, it's an acute non-suppurative communicable disease. Now, if it's bacterial infection of the salivary glands, usually there will be pus, there will be raised white blood cell count with neutrophils being higher. If it's viral, there will be no pus discharge. Now, sometimes mixed can happen, viral and bacterial, or super infection as we call it. It can happen. But if it's just one of them, if it's viral, there will be more lymphocytic infiltrates with normal to slightly raised white blood cell counts. It's painful non-erythematous swelling of one or both of the parotid glands, beginning 2 to 3 weeks after the exposure, which is the incubation period. Most commonly in children between 6 to 8 years of age. Pre-auricular swelling, pain, fever, chills, and headaches. Takes about 5 to 12 days to be resolved, and usually supportive care, analgesics, hydration. That's it. But the complications are risky: meningitis, pancreatitis, nephritis, orchitis, testicular atrophy in about 20% of young males affected. So that's the first part. Hopefully it helped pave some information and you enjoyed it. And if you have any questions, I'm always available anytime you want. So hopefully you've enjoyed it. Thank you.